ETC training school, police training school. We need to make it to be conducive. We have the local field hospital. That one also is there. We need to stand it up. We are thinking of other areas. If we do that, there are other requests that local needs that will come into play, which Dr. Kabadi, case management pillar, we talk about. Besides that, the surveillance. To break the statutory chain, our surveillance team will need to increase the boots on the ground. We, at the beginning of the response, were able to identify, on average, 15 to 20 contacts per case, per positive case. But down the line, that has reduced to between 1 to 2, meaning there's an issue with surveillance. We need to increase the boot on the ground, and also some of the challenges are they do the case investigation, but they are not entering into the DS because they are doing paper-based. And if you are doing paper-based, it's not the input. And if you don't input into the DHS, we cannot capture it to the dashboard. And that's why we are seeing those figures. The ED spoke about the continental visit from Africa CDC and WHO and US CDC. The observation was that our reproductive rate for this outbreak now, especially in the Western area, is 2.3. Meaning, if you have one positive case, if you don't take it out within 2 weeks, that one case is going to generate 2.3 cases. So if we don't do anything now, in 2 weeks' time, we are going to know what we have now. It is going to be disastrous, and we don't want that. We already know what to do, and we are going to put that in place to make sure we take the cases out. Engage the community to bring transmission chain, of course, their behavior and protection, and also for them to be able to identify the cases and report. Number 2, case management, pick them out. Surveillance, identify all the contacts. And maybe stratify them for low, medium, and high risk. We are targeting to facilitate the high risk. But that information has to come from surveillance. The surveillance has to do that. We need to give the number of surveillance on the ground because they look at the numbers that we are getting. For the past week or so, we are registering not less than 100 cases per day on average. And then for you to investigate those cases thoroughly, you may need 2-3 days to investigate the cases thoroughly to identify all of them. So meaning we need to increase the number of surveillance officers in the field to be able to do this. And we also need to digitalize the reporting. Because if you are doing paperwork and then later on inputting, we are going to create a backlog. And once that is not inputted, we don't see the information on the platform. And that also we have the data, the response. We need to have data that is readily available in real time so that we're able to take appropriate decisions to run it. So basically, if you ask what we want to do, these are the things we need to do to bring the transmission chain. Thank you.
Thank you very much. A round of applause for him, please. And I hope we got what he said. There are positives and things we know, so there's no knowledge gap. But there is a no-do gap. We know what to do, but we've not done it. And one thing scary is, up till now, it starts in community and ends in community, but we haven't got the community on our side yet. That came out clearly. Of course, all the other areas we need to do, surveillance, what to do, has come out. We need to stand up areas where we can isolate and treat our cases. Thank you. So I will ask Dr. Lako.
Thank you. Good afternoon, listeners. Dr. Kaba, thank you so much for joining the panel of this discussion. There are components in epidemic response we call the S. When you talk about any response, you need what we call the space. And the space here is talking about infrastructure. This is an area you are very much critical as the head of clinical services. Again, we talk about stuff. Build your infrastructure, but if the stuff is not there, the PPE, the medications, it will be quite difficult for a response to take place. There's a component called staff. Human resource is very much critical, as well as the system. So with this in mind, as the head of clinical services in the Ministry of Health, and with the current epidemic, what has been the preparedness, taking into consideration these resources that are very much critical in containing the response? Thank you.
Thank you very much. Thank you, CMO, distinguished partners. I think this is a very serious question. In any response, you have to ensure that you have the requisite space to manage people. That's why in pandemic preparedness in ensuring that when we have an issue, the space is ready, is very critical. Usually this space we talk about are hospitals. We stand up during pandemics or epidemics, isolation centers, but then we step them down because you cannot run them right through when there is no problem. They are so expensive to run. So what we have right throughout are hospitals, and this can be easily stood up to provide treatment centers or isolation centers, whilst you're looking at creating isolation and treatment. So we are cohorting them there in these 4 centers. But we've seen that because of the increase in cases, these hospitals will not be enough. And most importantly is that what we are doing is we have to ensure that normal service is delivered in these hospitals. Even if you have a situation where patients are cohorted there with an infectious disease, you have to ensure that surgeries are performed, pediatric services are given, normal services which these hospitals used to give you continue to give them. So you have to be very careful and mindful of how we do this kind of arrangement within our normal hospital settings. So the best idea is when you are getting overwhelmed, instead of opening so many wards and increasing the number of cases you are cohorting in your hospitals, and you might even end up muzzling the normal service delivery, you have to take the patients out to a place where it's strictly meant for them to be managed. That's why now we're opening the Potloko Center, we're looking at opening a center in Hastings and all the other places. But added to that, what we started seeing was that initially the patients were not walking into the facilities. We were taking them out of their communities. But there came a time we started seeing walking patients. So we had to be prepared in our hospitals to take care of those ones who come as a normal outpatient, and you have to take care of them. What do? We have to isolate them. We have to make sure that at least the initial first aid management is given, and then they are sent now to the designated treatment centers, which we have all over the country. So each hospital in this country has the capacity to do some form of isolation for 48 hours before the patients are sent to the treatment center. So we had these COVID structures that were built as isolation centers all over the districts, and some hospitals have them in Freetown. So these centers are being utilized. There are 4 to 10 beds depending on the space in the district. So we are using them for each hospital to maintain the walking patients whilst we plan to send them to the treatment centers. So this is a strategy on the space. On the stuff, supplies are being given through normal NMSA. We had supplies that we received recently that were sent to NPHA, and NPHA now has a distribution matrix based on the bed space and the amount of patients being admitted. Those drugs and supplies will be distributed. I must, however, say now that this is not enough. There is still need for us to improve, especially on our supplies. We hope that in the next couple of days and weeks we'll have enough supplies for those centers to have what they need. And we have to be able to predict what is needed in the next 3 to 6 months so that we have those supplies ready. And these hospitals should not go into their reserve supplies, which they need for routine services. So we have to make sure we have their own supplies ready just for treating these patients. Patients coming to our facilities should not pay. All the services we are providing in our hospitals and our treatment centers are free, but somebody is paying for it in the back end. That is our normal government systems, our donors, our partners. So the drugs and supplies have to be available there so that nobody resorts to paying for services in our treatment centers. So staff, this requires a lot of attention because when you have such an issue, people people have to be trained to manage it. People have to revise their IPC protocols and adhere to the guidelines set by the agency controlling the outbreak. So this is what was ongoing. Staff in these facilities were trained, the guidelines were disseminated, and reviewed, of course, reviewed and disseminated, so that at least these IPC protocols from Mpox can be integrated into their normal routine IPC protocols for hospitals when we have this outbreak. And now, we have to move our staff now to support the treatment centers out of the normal hospitals. So that's another challenge. So meaning, in some hospitals where our staff were, not many, we have to move some people out to get them to other centers. But this is something we're working on, so that at least normal services and routine services are provided, even though we might need to move some of our staff to a treatment center. So these are some of the things we've been doing around the 3 S's. Thank you very much for the question.
Just to emphasize one point that Dr. Kaba raised, and this is to clinicians, that we are not isolating the patient, we are isolating the infection. And the aspect of optimized supportive care is very critical. So don't isolate the patient, you isolate the infection. Thank you.
Thank you very much, Dr. Kaba. And Mr. Patrick Lanson, we have observed an increase in community transmission. And we have had, you watched the skits today, you saw that people in communities, there are those who do not even believe that they are Mpox. Because we have similarities with chickenpox and others, there are those with communities who say, I will know this. There are those who would think it is a myth or it is something spiritual. Then even where, as Dr. Kaba said, people walk into the community, into the hospitals, wanting to isolate them, maybe another. Because there has to be trust, there has to be reliability and understanding and care. So from your perspective, how can we really improve community awareness, behavior change, so that at least we can break this transmission as we go?
Good afternoon, and thank you very much, my able CMO. So, as Paul did mention, we are in the 3rd wave of the Mpox outbreak. Similar, it has to do with human behavior. The first wave has to do with denial, Mpox lobby, government will carry more money. Second wave, fear. Now we're in the 3rd wave, acceptance. So the 3rd wave now we are in, that's why we are on the right timing to have this kind of town hall meeting. Those figures that you see are real human beings, over 2,000. It continues to affect more families. New districts are now reporting. What are the challenges that we face as we do our community engagement? Low risk perceptions. Where are they coming from? You name but few. We not get Mpox as alone. Na doxally, na chickenpox, Pamamodu, Ogumina. Pegachi, na vaccine. Make a go income. Secondly, stigma is stepping in. Doctor was actually mentioning that people are walking out into facility. But you observe, those that are walking in are those that are actually going worst. Because there's this thing that you call sexually transmitted of Mpox, which is now creating stigma. Marriages are steep. Relationships are steep. So we have to destigmatize our messages to Mpox. So delay in health-seeking behavior also cause it's also challenging as we do our assisted work. As we move on, over 60% of our cases are doing home care. Our CHWs are on the ground. Our guys isolate within more than 20 hours. Now 2 bedroom, 1 toilet. Now, these are the reality that we do face. However, we have opportunities. It's just unfortunate that because for me, I would like the mic to go around, but because of time, that won't happen. But we have to do that we can speak for the community. The cases presentation actually changing. One of the presentations that we have are those with mild symptoms, just fever and rash. Those are the ones that use the OJO and vaccine. They hardly go to the facility. Those are one set of cases. And another cases are those that have only maybe minor lesion on the center part. Those early we want to go and report. But now with the increased number of stigma, that person look at Mpox, so there is stereotype in now. And they get Mpox and things say, if you are married, you don't go sleep with someone. Or you get multiple partners. So this stigma is growing. So the next comes now to delay. So I'm going to encourage all of us here. Let us Mpox is only passed transmitted to sex, even by sweat or at church. Let's don't chastise our partners that, oh, what's your Mpox? Those that have the multiple lesion on their private part and their body, those are the ones that easily walk into facilities. What is our strategy now that we are now utilizing now? We have what we call the community-led action approach. Sierra Leone is not used to pandemic. We have responded to Ebola, we succeeded. We have responded to COVID, we succeeded. And we also succeed with Mpox. I can see the victim. I can see the resources. Resources is not all about money. It's about community ownership and participation. And I'm happy that I can see the others here and our community stakeholders are. We need to actually work with our community and actually help them to develop the action plans because they have the solutions. As I can see, I cannot talk of what can happen in Boy and also outside the Boy as a day. But that Boy, they know where the sex occurs. They can engage them, identify key populations, use them as advocates. That's what we have been doing. Only yesterday, we met with a group of CSOs across the country. We gave them about 2 hours notice. The EOC was actually filled. They came in. That just can tell you that there are resources who are willing to support the process. As I speak, 7 districts will have support to implement this area approach. Goal actually have actually committed to support the Western area urban. They will be meeting with the HMT. For 3 months, they will deploy CHW that go around and trigger the community. With the pandemic fund, UNICEF also will be supporting 6 more districts, all volume districts, to actually implement that in Bombali, Western area rural, Cornwall, Kenema, Port. Also implement this community-led action approach. What the community-led action approach will do? They will support us with awareness raising, one-to-one church with community people. They will engage the community stakeholders to develop their community action plans. They will follow up on these cases. We are now trying to get every case from home to the facility, but it will take us some time. Now, within Freetown, we will up to have about 1,000 bed capacity. Currently, we have about 1,700 active cases. So there will still be cases in community. So our CHW will ensure that they support the case management team to follow up on these cases at home and continue to engage them because these are sort of our gaps currently. So we intensify our community action approach. Also, rely on existing structures. We have organizations that have been working with special groups. We have a political group like the commercial sex workers, person living with HIV. The last time I checked, about 7 of the deaths are persons actually who have condition of HIV. So we are working with this key population to ensure that they are treated as engage their own population. So what we intend, and also do what we call social and community listening under infodemic management, where we can normally call a positive conversation. We do listen to what the community is saying. Because if you don't listen to what I'm saying, you don't know what I feel or what I mean. So we will listen to what they are saying, and that informs our messages, and that also informs our strategy. Finally, the fight to Mpox does not remain in the hands of the government. It does remain in the hands of partners. And not only rely upon financial resources, we rely upon commitment from our community stakeholders. With traditional and wisdom, it don't have everybody's response. Mr. Abdullah Bangura. They have been doing what we call far because we have engaged them. Say if possible to now, we send it to the Mpox, refer them on the facility. I went to Bombali. Some cases that went there were referred by the Depression Airline. So that's a plus to what to their support to the pillar. We have like CSO working with youth. They are also engaging. A group for basically with disability, one family people support us to do freely that we do that will actually protect them. This is what I'm saying about resources are within us here. We don't have to look external for resources. It's how we mobilize, how we take it serious. So we need to save our account. If we continue in this trajectory, projecting for the cases, Sierra Leone will be isolated. Last time I checked, when I joined the African International IMT meeting, Sierra Leone last week we actually donated more kids than most other country. These are real people coming from real family. So please, as a nation, let us come together. Be you school, be you married woman. Let us avoid this stigmatization. Married men, those who have a partner. Because now, what is killing the response is stigmatization. When we start, we have 20 women to 80% men. So that explanation now is not pushing that most of the transmission is through-sex. So for that, a huge amount of stigmatization is going. So we have to actually, we are currently reviewing our messages to ensure that we reduce the amount of stigmatization. Our objective, because we're also within the next 3 months, so we should start to record single-digit cases. With the participation of our ownership, the case management system in place, because we believe we can support our surveillance code. The community mobilizers on the ground will support each other. That's what we have committed to. We will ensure that we engage 100% of own critical cases within the next 3 months. Daily, we will be engaging them. Last time we checked, for a survey done by UNICEF, awareness cases is around 60%. We will increase that awareness to our community to 95% within the next 3 months. The stigmatization, we ensure that we reduce it. When you walk into a health facility early, within 2 weeks, you should be cured. Why you will delay in health facility is when you delay, when you come and then you delay to actually see behavior. So we ensure that we improve anti-LCK behavior. So Dr. Kaba, I will actually that patient that we will be going to your facility will not be actually in what case we will go. We will engage our community people. So we ensure that we increase our LCK behavior by 40%. Currently, it is done for now because of the stigma. So I think on behalf of the One Health Tax team, and with the blessing of Mr. Thomas, I'll have to stop here for now and then I'll wait for the question. Thank you.
Thank you very much, Mr. Lansana. You brought a lot of things to the fore, that we are now in an acceptance phase. We have the resources at our disposal in here that is not money or government. You spoke about positive Congo-San and the things to go, so we need to really use some of those things. But at the same time, you brought out few things which maybe we need to reconsider internally. That means our messaging. And I always say our actions and inactions can create problems for us or make things easy. Our own actions and our words are stigmatizing people. So the people are in a state of fear. That tells me straight that psychosocial needs to team up with social risk to really alleviate the fears of the people. We should not limit psychosocial with case management now. they have to. And we did it a lot of times. During Ebola, during COVID, no pillar was going alone. When going, because you told me, you told us that it is the severe cases that are coming. The simple cases are in the community. But why are we not knowing them? It's possible you are going alone. So we need to go back to those old times when you are going, contact tracings have to be with you psychosocial. Maybe we will get positive DVD as we go. So I want to thank you very much, and I give it back to Dr. Lako.
So thank you so much, Mr. Patrick Thomas. Dr. Masuluku, we have seen a pattern, and truly it's not unique to this epidemic. In Ebola, the same pattern is seen. In COVID, the same pattern is seen. Now, more cases are reported in Freetown, Western area of the district where you serve as the chief of health. We have significant challenges considering the population dynamics. When Mr. Patrick was talking about key population. And when you look at the population size estimate of 2021, it tells us that this is where we have the highest number of female sex workers, one of the key population for Mpox. And again, looking at MSN, a similar situation across. The population dynamic is very unique. At this moment, reporting high number of cases, 50 or more, many of which are from Western area, poses a significant challenge. You may be overwhelmed. Can you please dilate on one, your experiences in terms of the work you and your team are doing in addressing this problem in Western area? 2, what challenges that you are facing? And 3, talking to this audience, how they can come in to support and address this ingrained problem in the Western area. Over to you, Dr. Masolo.
Thank you very much, Dr. Lako, Chief fellow panelists, partners, colleagues, and our guest. At district level, we translate all the strategies put in place by the national team into interventions and activities to halt transmission and bend down the curve, and at the same time maintaining routine interventions. And as we all know from lessons learned for Ebola and COVID-19, we know that Leone has a very strong surveillance system. And thanks to the success of the COVID-19, the way we managed it in Sierra Leone, and that actually is a testament to that fact. But however, we know that during the Ebola outbreak, it was very close to the end of Ebola that we actually incorporate the community aspect. And during the COVID, we incorporated that earlier and we saw the effect. For the Mpox, some of the challenges we faced during the Mpox outbreak were the top-down health messages, which actually led to resistance. But you see that we are actually taking, a U-turn in terms of that, because I think some of those messages we were supposed to develop with the communities, and that we are doing now. And also, we had the initial underreporting, which also tied to the community, because if communities are not engaged and well involved in our interventions, then automatically that's will affect early case detection, especially in limited resource environments that we find ourselves, and also where turnaround for lab was initially, there were delays in confirming cases. However, we have other challenges in terms of having the infrastructure for treatment center. But currently we have hospitals and maybe few centers that do have isolation, but you see we are actually scaling up that now based on what my other panelists have already mentioned. resources, because for us to adequately or effectively respond, then we need human resources at all levels. And also, we also know that even engaging those communities and doing all those contact tracing for the CHW program, we realized there was sort of step down or reduced funding to the CHW program. So as a result of that, we have limited CHWs to actually, not that they are not there, but to actually, or even incentives, and even with the incentives, how regular are those incentives to actually bring them on board. Also, challenges we're also facing at district level, how to navigate, partnerships and funding, in this dynamic global financial landscape, and also we looking at local emergency funding at all levels. What we have currently for emergency funding is practically low to not available. So as a result of that, it's difficult for us to start, even though we can start responding, but challenges with resources actually affects outcome or output of our interventions. So moving forward, based on all the strategies that the national have put together and that we have started implementing, at district level, comprehensive, robust intervention, including all of the pillars being activated. And also because overall, what the Mpox has actually reinforced is that evidence and event-based surveillance system and community level reporting is really key, especially when we are seeing delay in laboratory confirmed cases as a result of low resources and turnaround time. We have to, and as a ministry, beefing up the community engagement aspect will help us get communities on board. And the community healthcare workers, for the community healthcare workers, I believe moving forward as a country, we should look at how we can have that institutionalized within our system, where these community health workers can be paid. So it's easier to just, piggyback on that resources, or that human resources when we have such outbreak, so that the community aspect of our intervention or surveillance can be strengthened in that regard. And also looking at further investments, in emergency prepared funding, initial emergency prepared funding, because that's still a huge gap for us to start basic interventions at district level. And to also look at how we can improve on the participation of stakeholders, like community stakeholders. We are expecting that most of our interventions, we can get those community stakeholders to take out the messages out there and help us to get those patients not only to treatment centers, but also for them to continue to appear at our PHUs and also to report them through the surveillance system within the community, because we do have a community surveillance-based system, but just that whenever we have outbreak, we need to bring the community on board to get that activated or maybe supported to institutionalization of the community healthcare worker within CNM. Thank you, over and out.
Thank you so much, Dr. Fasuluku. Just to point out at one issue, the area around bed space. The epidemic we have two components. And one component, people often consider it to be part of case management. The aspect of suspected cases should be integral to routine hospital care. And this is an area that we want to advise. We do agree that you may repurpose extensive isolation centers, but isolation centers should be part of hospital systems. When you do that, you safeguard yourself as an individual, as an MS. You safeguard your staff, and you safeguard your patient and the population that visit the hospital. So it is very critical that we should not miss this. This should be integral if we want to respond to public health emergencies. But the second component is around resources. It is good when we say we are preparing or responding to any epidemic. We do it much earlier as a country and as partners. Because the more we wait, the more resources that we need. When the epidemic started earlier, you see some of these patients in pain. Any human being may want to say, if I have the resources today to support the response, so the suffering of Sierra Leone, as painful as these lesions are, as disturbing as these lesions are, as extensive as the skin changes may be, it is very critical that we respond early and prevent the suffering among our population. So thank you so much, Dr. Faso.
All right, thank you very much, Dr. Fasuluko and Dr. Suleiman Lako. We have one more we have had so far from these technical experts. I'm not actually expecting questions from Ministry of Health or technical people who really wanted the voice of the community, people who live with it. The thing is in the community now. So we'll blend it because of time, given that we have another talking about hearing the voices in the community from the field. So I now take this honor to thank all the panelists and ask you to go down because we'll not be because of time. So a round of applause to them. And I may say, Mr. Lansana, can you now help to call on stage Mr. Samura Mohammed and the team of community people who should really follow. One has to be a survivor, a moderator. I mean, the religious leader, Focus 1000, the women's and youth leaders. After that, I will come on stage to call our Deputy Minister to close.
Hello. So, thank you very much, Dr. Satikana Sebo. I'll now start by calling Magma Kaifona. She's one of our female advocates in county, Leone, women in this area. Then I will now call upon Asimanga Kaifona, find her way up. Thank you, I welcome the short notice to actually accept our invitation. Thank you for coming. Now, one of our champions who feels it, knows it. I'm not calling Mr. Nelson Johnson, who has been through it all and is survival of Mpox. So, Mr. Nelson Johnson, can you please join us on stage? Who feels it, knows it. So, we actually tell you about his life experience. The data was actually very clear that the youth, we are the ones that are more exposed and we are recording the cases. So, Mr. Samoa, I cannot see you already welcome. Fine. So, Mr. Samoa, can you please join us in the table? Thank you very much, Mr. Samoa. For Sierra Leone, we do have two religions, Muslim and Christian, official, and a representative of the Interreligious Council, Reverend Pastor Cargo. Do you want to join us, please? Please let me ask Reverend Pastor. And then a representative from Focus 1000 as a CEO that is working with the committee. We also actually need to join the panel. Focus 1000, please. So now maybe we will start the session with the Focus 1000. Thank you. So again, welcome again and good evening. I think it's after 5. Our appreciation is actually a commitment that is someone is increasing on time. It's a commitment that we're in a peak, and this is the most important aspect. I spoke about resources. These are our resources. Now they're going to commit themselves how we are going to move fight forward to actually break the chain. So thank you all for actually coming with initial notice to this panel. So let me start with Mr. Johnson, who have actually been to it all, who feels it, knows it. So Mr. Johnson, what was it like for you when you had Mpox? Take us through your experience, your life cycle, from the time you actually notice the symptoms till you survive, and now you're happy and strong. Please take us through your experience, Mr. Johnson.
Good evening, everyone. As an entrepreneur to start with, I went to go on a particular program, which was organized by the ministry, and went there to pitch for a grant. Unfortunately, I didn't get a grant. So when I returned back, my brother said, "My brother, you don't get money now, to put it on my face." I didn't get the money, so I come with other thing. So he was provoking me, but I didn't take it serious. So my auntie said, "Can you please see the nurse next door so you can check what is the problem?" And my younger sister said, "Don't worry, my dear, I'll buy you beggar. It's just chicken pox." So all of those things. So I visited the nurse next door, and she said, where have you been affected with this stuff?" So I explained to her. She said, "My brother, I don't want to be infected. I advise you go to 34. So I went to 34 and I was tested, but on that day I didn't get the results, so I have to come back home. But our home is that kind of stuff that immediately my auntie has that Mpox, there's that kind of mandate. Everyone has to stay at his own position, so we don't mix that kind of way. So the next morning I was called, "Mr. Nelson, you have been positive, your result is out, you have been tested positive, so can you come for admission?" But I'm somebody, since I've grown up, I've never been admitted in an hospital, so I decided to be adamant. I decided not to go to the hospital, and my auntie called me. In the next 10 minutes, "I want to have from a doctor that you're in the hospital." I said, "Okay, no problem." So I packed my belongings and go to the hospital, so I was admitted. But my own case was not that serious compared to others that I met in the hospitals, because I didn't know how I get in contact with the Mpox, to be honest. But for about 30 of us in the 16 of us, I think, at 34, 3 of us, we are saying that we didn't know how we got the Mpox. But out of the number, 10 of them were contact disease through sex transmission. So, like, And those that have this, they were infected through the sex transmission, their cases were more serious compared to us that got it through maybe contact. So when we were in the hospital, and I saw most of the pictures that were displayed here, I was in that group. Those pictures that were displayed here this afternoon, I know most of them, I was with them anyway. So in fact, because I'm that kind of person who normally talks to people, encourage people, and that hospital I was the one encouraging them that don't worry, my brother, this is going to be easy, take it easy, don't be panic, it's something that is going to be passed. And I learned most of the information from Mr. Thomas. He normally goes to the radio station and do that kind of publicity and make awareness. So I started administering treatment, and my treatment was not too difficult. But some of the difficulties in the hospital was like one, most of the medication were not available. Some were not available. So most of them, the doctors can give you prescription, and they can tell you that, okay, can you call one of your family members to buy? So your family members will come and give them the prescription and buy the medicine and come with it back, because you are not allowed to give your prescription to a nurse. Because remember, these are military officers and they are very strict. And to tell you, to be honest with you, that is my first time of being admitted, but the nurses that are in 34, the military officers that are in 34, kudos to them. They are really, you can call them at any given time, midnight, every time, and they're ready to respond. Hello, Nauda, Namio, this and this is the one Namio, so now for Kamba more cancelling they are, and they are ready to come. So you can be treated, and even after my admission, and I take on the challenges that, okay, I didn't get money, let me return my own service to the nation. So after my discharge, before I discharge, we form a group. We are about 150 in that group. We start advocating, sensitizing people about the Mpox in the community. And most of I go on social media, a few days back before coming here, I saw somebody posted Pegagin. This is the right medication. And I chat to the individual and tell him, that is not the right medication, my brother. Put it down. And to be kindly enough, a dig. But now, there is a difference between Mpox and chickenpox. Now, when it comes to the Mpox affects the genital area severely compared to chickenpox. So people do mistake chickenpox for Mpox. Like, get the chickenpox, they tell you, just go and buy Pega. And sometimes before I met Mr. Thomas, we met at the TV station. I met a woman infected with Mpox, and she was buying Pega. Somebody, and this thing we call this white clay. She mixed it with the Pegagin and pour it all over her body and said it's just chickenpox. And I asked, where are these things have been affected? And she couldn't tell me. So I have to be very plain with the individual. Because I don't know her. That is the first time, and I call her the corner. Remove my boxers and have you seen some of the marks? So don't fear to explain to me. I have been infected. I'm not a survivor. So I sensitize her, and she will go to the hospital. So most people don't really know when they have been infected, what is the difference between Mpox and chickenpox. But the treatment in the hospital are very good. And for 34 hospital, the nurse is especially one of the captains that she's in charge of the infected area. That captain is a good woman. She's dedicated to her work. And she makes sure that every nurse is always present in the hospital and on time. So I didn't take long in the hospital. I took like a week. I was discharged because my case was not serious. So some of the things that helped me was early detection. I detected early and make sure I went to the hospital and take my treatment.
Thank you very much. A big hand for Mr. Johnson. So there are two key takeaways from Mr. Johnson's statement. One has to do with the role of influencers. We all do have people that you can influence. His auntie was the key influencers that saved his life. That allowed him to go to the hospital again, because he's not someone that had ever been admitted. But when the aunt called and said, "The man, go and say," he went. So please, as influencers, if you have people that you can influence them to take the right action. And ILC can be also save my brother. So thank you very much, Mr. Johnson. And we'll now go over to Reverend Johnson. Okay. So now we can go on now to Reverend Johnson. As I've been saying, this part now world don't face Ebola, COVID now. Reverend Kako now world face Ebola, COVID now with the vet Mpox. So Reverend Kako, what do you think say now the community, their perspective about Mpox? And as you all as a religious leader, what do you think say we not done the do? You know, it was supposed to do, and what do you intend for now for break this chain? For most of for the reports, I know about cases. Treaty what they happen now. We get some misinformation they go. Bigger chain they mean Mpox. Not to Mpox and doxal and chickenpox. Then stigma they come in terms of the transmission. Waiting and then the home treatment. Waiting say now when you go as religious leaders, how will I go for help? So you can make a commitment now on behalf of all the religious leaders in the salon. Thank you, sir.
Hello, good evening. Thank you very much. So my name is Reverend Alimami Papso Kago, Dr. Johnson. Okay. So what's in our perspective? I'm sure we already know, if not 99, at least a high percentage of we belong to either Islam or Christianity. True of us? Good. If that's the case, I think we are more than worried than anybody, except the government when I recover for you all. But how we going to do? So in terms of perspective, just the usual one where denial go day, the usual one where myth go day, rumors go day, lie go day, and they talk one kind of thing way spiritualizer. So broadly, I think those are the perspective. What we don't do, I think say you go agree with me like you rightly said, the Interreligious Council comprised of, should I speak English or Creole? Oh, fine. Okay. So you know, all the major umbrella organizations in a salon belong to Interreligious Council of Sierra Leone. We mean to say, and this is headed by the Archbishop, His Grace Edward Charles, assisted by two vice presidents, one Aja Mariama and Alaji Mutada with a medical person. So when you say anything we decide now, freedom, when our headquarters for Interreligious Council is spread across all sectors of religious society in our salon. Because all umbrella organizations that belong there and the heads that then form the executive of the Interreligious Council of Sierra Leone. So what we don't do, immediately the issue begin come up. I think St. Patrick will agree with me, Mr. You and your colleague staff when I engage me. I happen to serve as the national coordinator of the Interreligious Council of Sierra Leone. We get about 500 networks. 500 networks across the nation, 16 districts of Sierra Leone. Every village, every chiefdom will get one Muslim, one Christian when they serve as coordinator and nationwide. So at the coordinator, we get WhatsApp group. And so immediately the information begin come, of course the infodemics begin come for, so we had to counter and tell them, say, this is no joking matter. So in addition to what we don't do for COP the first wave, we certainly they give positive information about the reality of the issue at hand, that Mpox is real. Okay, but also I think when I invite you, we have gone to 2 or 3 sensitization workshop, EOC and other places, so that we go pass on. And I think say you ask me for bringing along Muslims and Christians to those meetings, and they replicate the information they get from UNA and Kegu. In addition, we belong, for me, I belong to over 30 WhatsApp groups there. And so, people look up to me for give cogent information about health issues, especially the one who I know about. So, what I get from now the person. But not tap day. Even this Sunday we pass, I invited officials from Ministry of Health, Jonathan Pesima and others. They go do slide PowerPoint presentation in the church. And immediately they do, you will see the response of the people for saying they were interested in the immunization, the immaculate, right? So when we just say, and we each time I get information and they pass us, so we pass the information all about, and the people are anxious now forget the vaccination, because when it was COVID, it was difficult for convincing. But now that they get the information and they see the reality, especially the pictures that they send, they're so graphic, and the people get every reason for belief, and they are yearning to get the vaccine. I think that's the thing. The issue of denial is not so much rampant as it used to be when we had Ebola and COVID. And I think so we are readily available to make our resources available to UNA, all of us. We work as Cobra. We are more than interested in the health of our members than any other thing. Yeah. So even if we not get coupled, I think it's enough, because what we can feel normally, the government say lockdown, that they affect me very seriously. Not because of the offering we raise in a church or mosque, but just the fellowship, the gathering. We like that. So we know that lockdown. So we are doing everything in our power to make sure we pass on the information. And the way you talk about, instantly I may ask the question, one day we get that last information that government sent, but we'll see the health measures for take, get Veronica bucket and washing, etc., etc. So they ask the question: is government going to close down? Is it going to shut down? I think it's a big possibility to know we don't reach the 8, and I'm not sure we want to reach it. So we have to do everything in our powers, everything humanly possible for make sure that we give them the full support for make sure this thing become a thing of the past, because we don't get experience, we don't have to lose lives. We don't say what 11 people they're not there. I think it's not good to write home about, and we don't like that thing. So we are saying we will lend our support to the Ministry of Health for make sure we spread the message all across, all of us. I think I've tapped on this so far.
Thank you very much, Reverend Cabo. So, Reverend Cabo just reaffirmed the commitment of Intelligence Council. Then in the last village, every village get a pastor or a imam. So thank you very much. No one say we mess for Mpox to reach the last village as alone. Thank you very much, Reverend. And also, he also called for the health authorities advocate for more vaccine. Now, we're not giving any vaccine, we probably the call for vaccine. So now, with the call upon the Deputy Minister, the CMO, let us advocate for more vaccine for Ghana. Now, over to Auntie Mama California. Woman then, based on our day at high risk. And the figures are set detail. Now when you look at the percentage, it's about 53% of male for the percent of women. So we would get an increase for the past 2 months, about 27% jump. When you look at the one we don't die, we'll get as per yesterday update for the public. So three we don't die. 4 a man, the rest 9 a woman. On that high risk. How on earth if you say we go keep us the 2 money for support to be for this change and maybe we're open for talk to a couple money for support to man. Thank you, man.
Thank you so much. I'm so happy for the year today because this
something since I like to be 30 minutes, then they call me for Kaya, so I will still watch for Kaya because I've seen waiting the disaster we outbreaks that the risk bring on the lives of women. Then, you know, I saw it all in Kenema, 2014 we Ebola camp, in 2019 again we were involved with COVID camp, and then we see this one safe one camp and begin for takeover where we don't get a chance for takeover. We know women are always vulnerable, and I want to say kudos to women right now. We are so conscious of what we do. We so get that kind of resilience. We always want to stand out, so not they be any like a first thing. When they make anything they happen, they find us with the woman and we can start for push and before, for less of the happen before the man they can't join me. And that we don't see where they happen, especially by this Mpox here. Because now we they talk to the beginning, now we they on the beginning, you know, misconception, the one come, but we don't go before. Don't begin for create the awareness for help people there. You know, the good thing about the civil society activity business, women they enjoy, I don't even let them pass the journalism in my specialty. You know, getting myself involved into communities for help people to educate them about what really happen on the health sector, and I find so much pleasure. Because now, we don't make sure say, even the women in the last time communities, them, we are serving as a food soldiers, we help the surveillance committee, the surveillance team, because when we go ahead of them, when we go begin to talk to the woman there, we then tell them about the dangers if they decide for continue, for hold on, for accept the truth, it will affect me like how Ebola will affect me. Because when Ebola became, the meat was so much, the misunderstanding, misconception, everything put together, they make women not really come out. And now we don't begin to women don't begin die by this. And we don't want to see more women that die. Even the man that we don't want to see they die. The man that don't go first in the country. Then they go die now, not to Palampo, but business within this country go. And we not go want that. So we they make sure say all the messages them way we they get. We will help for change the mindset of women there across the country with the push and go before. With the tell the woman there. You know, recently we began for tell women about this Mpox. Who don't mean to say it will can't be this serious. We don't go ahead with the tell women there. We don't go to Kamalaka, we don't go to Kaboi, we don't go to villages there where we know say that the women who they operate for the women they get understanding. We don't go to places that will be sweet no say now mining areas there where women they come they go do forgive me sex work business. And we don't begin for tell them let them understand say this secret pass two different means. So they get forget that understanding. They don't get for make careless for anything. And recently the National Public Health they call me for together with the CSOs that they show how serious the day for face this sick. And waiting we don't go learn out of the things that they tell we say they pass on. So the people there, what will they work with? They market woman there. Now make a glad they will come to their see woman the way they suckle, be there I feel like when they outside right now. That is shown how serious woman they take this tears. We don't downplay at all. Because first them, when they go around, when they talk to people there, they say na chicken pox. And a chicken pox, so the best thing for men na total pack. So this day beyond total pack. Oh, show and mix the total pack in the show. We say this is beyond that. And people don't begin get the understanding say it is beyond Ojo, it is beyond total pack. I don't know if the man is submitting a Ojo. That white thing when they keep put per woman there when they can go na society bush. So people that use them also, they say they make chicken pox. But this is not the make Mpox. So we try to make them understand that say it's different. And recently within a Kube, we they educate people the way they did that slum area. We they tell them say that chicken pox. We say not to chicken pox. Mpox different. Then if you say that government want make money, but we don't make them understand say government don't want make money out. Whose government? What go want for making people that they die, they need money. Don't put politics man, these parents there. Let us face the reality. Because when the thing they come back, even the health workers, their lives, they at least they said go die if you not eat this seriousness. And most of them are women we not go tire for sending message now. We dey make sure say even the least speaking at the school step, we dey tell them about this Mpox. Make them understand say Mpox serious, and it go stop if we all put hands together. It go stop. And these 2 months we will fight for, we have feel say if every woman time or jam, Mpox no go pass 2 months na salon. Because the kind trend at which we go right now with the awareness raising. Because I can be, for me, example, I not only there with the market woman, I not only there with the CSO, I join other CSO groups there. And for me, like for example, so new organization, I not only find myself on one side. I dey Konadugu, I dey Kenema, I dey Kaine, I dey Putloko, and I dey Western area. So I get team of women there, I need to get man them. Why they work with follow with help? We don't need to wait for money. Say, Pastor, give me money before we tell people them body sick. That's not, we can make the mistake, na salon. Don't wait for money. Start pushing, start creating awareness. Let people that know say, hey, people that will die again, people that die again, be sick, we will stop her. With or without money. And salon will be a better place. And the other thing I want for them, we know. But this year, so the way people they begin at the mind, where we all women for every other woman, people they say I will show. When Mpox go, they go to the community, they say I will show. They say I will show, now you don't come back. You know, say don't tell the neighbor will show business. How will show go past one person? Like how we stop Ebola. Ebola be bad, but we able to fight them. We don't. We risk with life. For who they care about the call and say we will not sign. We didn't know, but I make a glad you see Dr. Vanti and also. Because I remember when they attended pillar meetings, you know, we fed them and it don't. COVID camp, so it be easy for women COVID camp because we know the practice system. The distance, wash your hands, stay away from crowd, stay away from harmful practices. The thing will make you get infected. And delicate the way Mpox talk, we are passing on that same knowledge what we don't get. For help people then, for make them go obtain and maintain personal hygiene. Salon will let for shake and 2 months. Even a year, you don't pass 5 people the one for can shake me. Because see, I've seen a culture, but not a culture, a bad culture that they will also avoid that one. And then mama and papa, if you not you suspect say you don't begin get fever. If you cause you don't forget sex for 1 month, not get sex. Because you go not for spread the seed. Tell you partner. Go get test and no say no get Mpox. Because if you go do mama and papa business, they go get Mpox now. Who don't go belly bikini. So I want for encourage you. As we effect, una join me all, follow me faith. And as the National Public Health Agency don't with me together for this, one for say big thank you to Mr. Howard. Of course, you guys are doing a fantastic job. Because if you know they call me for camp and meetings, for camp educate me, what will they tell the people? When they start waiting for talk. When they give me the accurate messages, then when they can go. When you make people they understand, say this, now so you get this sick here so. But now so that you will prevent this sick. And if you get them, like what I said, if you rush to the hospital quick, you go well. So then messages they don't give me, it help me. Thank you so much.
Thank you very much. I think another commitment from the woman there. So now, Mr. Sama, they say the last man say the small time. So Mr. Sama, please, within a very short period of time, we the youth then now get a number of cases then. Which innovation will now use to spread the message then? And how that things say the youth they work for support for stop the sickness in salon?
Yeah, before I come to that, a quick one. You know, we as an organization, we get few things that we get as concerned in the fight against Mpox. One, na compliance on the guidelines that the ministry don't pull, the Ministry of Health. How effective, you know, people that they actually apply, they comply to some of the guidelines they have. And one of the things we get for do some on-the-spot check. And we get for they also provide the NPHA with updated information on feedback what they get, so that we can get more collaboration with the security personnel, just like when we get COVID and some other, disease outbreak, we've been, lead to the development of the guidelines and the, because if you look, most of the program, the way they happen now, it gets tendency for make at least people they get the transmission, because the carry people in the cluster together, the kind of way people in the shake hands, the kind of way people in the hug, and to do some other things the way they are above the guideline, that way really worrisome. Then secondly, the essential services, because these are one of the things that, again, they impact on the uptake of essential services, other essential services. We don't really want to forget to a position, also will be there like Ebola. People do not really go to the hospital them for go actually get the different health facilities there. And we don't make significant gains. We did earlier this morning, where we from different ministries, departments, and agencies, they announced the gains, so we don't make. These Mpox get tendency for reverse then gains than they if we not take the right steps. And we really need for put measures in place. And I'm so happy in one of the meetings where the minister been confirmed saying yes, they get infrastructure, they get a whole system on that for make sure say in as much as in the first Mpox, they also get other interventions where they make sure say community then actually take up the other essential services. Coming to we the young people then, which we don't actually consider as a way of engaging and increasing their awareness about the Mpox messages. We therefore engage social media influencers then, especially the WhatsApp administrators then, because if you look at the flow of misconception, things that were not correct about this Mpox. In fact, not only this Mpox, but diseases that we don't get now from the social media at the beginning. And we see a lot of things that will happen. So we therefore engage these social media influencers, we therefore train them, we therefore, of course, we therefore invite to about some of the capacity development training them, for make sure say they're able to track, encounter some of them, misinformation them, things that were not correct about the Mpox. So if you ask me, I think we have plenty, but because of time, I will just limit it to this one. Thank you very much.
Thank you very much, Dr. May we give round of applause for all the panelists. So I think now we can make two positions now. So I will now call upon the CMO, Dr. Satikane now, to take over the mic, sir. Thank you, sir.
Thank you very much. Another round of applause for this time for all of us. They say, quitters will never win, right? And winners will never quit. For us who did not quit, who are still here, kudos to us. And this is the last act of the day. And it now gives me pleasure to call on our Deputy Minister of Health, Professor Charles Senesi, to close this second part of the day, the sessions, and then after that we'll hand over to Dr. Tom Sise for any announcement.
Thank you very much, David Sise. And colleagues, I think we have really persevered at this level. So once again, thank you very much for being with us. And again, this session has been quite lively. That's the first panelist. We have some specialists in the medical areas. They are showing us. Despite the pandemic seems to be overwhelming us, but we are able to be on top of the situation. And of course, we've gone through all the phases support, the phases of surprise. There are normally 4 phases in social sciences. You go through the phase of shock, and again, here we are. We went through the phase of denial. Lots of people are still resting on this phase. And no, this is not Mpox, it's Mpox. But then, of course, there is another phase that what would we have done better not to have landed in this situation. But we never rested on that. We went to the coping mechanism now, where we are. And indeed, as a government, we have done everything we could to make sure that we continue to optimize our efforts to keep involved and bring the pandemic under control. In the areas of infrastructure and development, I think as I speak now, we decided to take the cases as our colleagues have alluded earlier on to make sure that we put them into treatment facilities I was at the police training school yesterday, and a lot of progress has been made in terms of, it's quite emotional to see us going down this way again, but this is life, so we're able to bounce back. That resilience we have as Africans, as Sierra Leoneans, to make sure that we don't, no blame game, we're looking for solution. So I was there yesterday, and then there's a lot of progress, and when I leave here again, I'm going to support the side to make sure that we continue to do the needful. And I'm really proud as a Sierra Leonean that our government has taken a very good leap yesterday in affording us resources that we need, especially financial resources. I congratulate every one of us in this room for actually going where it is of finance and give another check. Of course, it's not enough. The development partners are getting big, and we still have resource gap. We hope that we will do more resource mobilization, because the more resources, human, material, and financial we have, the more we can take the call. So we'll be going bilateral again to reach out to you colleagues to say, listen, we can do this, and let's do this for humanity. And I'm happy that the treatment guidelines have been optimized on the laptop. We now have the national guidelines, what needs to be put on those wet lesions or the dry lesions. That's why we really optimize it in the Sierra Leone context, based on evidence in the medical field. So, of course, the issue of stigma still keeps coming up, and I think we do the needful to make sure that we overcome the stigma and let the patient have that respectable treatment. And community engagement again, pandemics begin and end in the communities. I think we saw a lot of that from the experts and also from the people who have experienced the Mpox and those who supported the others, thanks to the medical professionals. We continue to rely on you heavily as we move along. And of course, the human resource area, we are able to mobilize human resource, thanks to our human resource department, to the nurses and midwifery council, and all those who have supported us to put together the equity staff we need to stand up that facility around the countries as early as tomorrow and the day after. I think it's been wonderful and it's very fulfilling what has happened so far. Of course, we understand now the pandemics, we know what's going on, we know the age groups, we know the hotspots, we know the mode of transmission, which is totally changed in Sierra Leone. What used to be lower down, the central transmission seems to be driving the pandemic. We know the age group, we know the hotspot, so I think we can go in, knowing the problem, you have 50% of the solution. And we are very determined to enter that space and make sure that we do the needful for the people of this country. So at least we can put this behind our back. So I know time is well spent. I don't want to go through all what I said earlier on, but I'm sure that we are doing everything is going to go by science. In every pandemic, every infection, those three factors, the virulence of the virus, we know it's not as virulent as others. Our immune system, which we don't have so much control over, what we have control over is the dose we see. So we are optimizing our IPC controls. We now see that all the hand sanitizers are going to come out. The good news is that we have learned how to manufacture hand sanitizers in Sierra Leone. So I'm sure CMO, innovation boost we are very happy for that. And once again, we thank everybody, we thank our development partners, and including every one of you that have stood by our side and continue to stand by our side to make sure that we bring the pandemic to an end. We thank you very much and have a pleasant evening.